Hi, my name is Yuriy Kolesnichenko. I'm the sonologist from Moscow, Russia, and today we talk about inguinal hernia and the practice of pediatric sonography. An inguinal hernia is a condition in which the contents of abdominal cavity enter the pathoid inguinal canal, and not only fluid. The presence of only fluid is called hydrocele. And this includes the cystic form, the nuke cyst in female, and spermatic cord cyst in boys. In case of inguinal hernia, the contents of the hernial sac are usually the greater omentum and intestinal loops. In boys, when the hernia reaches the scrotum, the hernia is sometimes also called the inguinal scrotal hernia. In female patients, an ovary can also enter the hernia, which can sometimes be confused with the mass of another origin, for example, in nuke cyst. In my practice, such hernias was always strangulated and require emergency hospitalization and consultation with a hospital surgeon. But of course, sometimes such hernias can be not strangulated, and in such cases, ovary will be not alone in the big hernia sac. If you have doubt that cystic or solid cystic mass lesion identified in the groin area is an ovary, then look for ovaries in a small pelvis. If you have not found them, then urgently send the patient to the surgeon. If you do not work in a hospital, then it is best to bring the patient to the surgeon's office if it's in the same building, personally, and make sure that the surgeon is there, hear you and understand what is being said in your case. Because we are all human, the surgeon may not be there, appointments are often overloaded and doctors get tired, patients make noise and distract doctors who often do several things at the same time. If the surgeon is not there, then go to the district or duty pediatrician, head of pediatrician department or higher. Otherwise, in the event of unfortunate coincidence of circumstances in the future, a representative of law enforcement agencies may want to talk with you. Some tips for performing ultrasound of inguinal canal. Polypositional scanning, especially if the hernia is not visible in the supine position. Then it is imperative to scan in the standing position of the patient. Sometimes the patient is also asked to bend slightly back or to do a Valsalva test, deep breathe and strain the abdomen. In the case of small children, when you need to scan in the standing position, you will need one more person, a parent or an other adult accompanying the child, a doctor or nurse. If on ultrasound you visualize a filled bladder and do not see the inguinal hernia, then it is imperative to do the follow-up ultrasound after emptying it after urination, because the full bladder can interfere abdominal content to enter into inguinal canal. You should also understand that an inguinal hernia will have to be differentiated with other mass lesion of the groin and scrotum, in particular with enlarged lymph nodes, as well as with lipomatosis of spermatic cord and idiopathic necrosis of scrotal fat, lipomas, liposarcomas. The ovary can also enter the femoral hernia. Even the gallbladder can enter the femoral hernia. Ovarian torsion may occur in inguinal hernia. Testicular torsion may occur in inguinal canal and can be associated with inguinal hernia. An inguinal hernia may contain the bladder. What else is desirable to indicate in the conclusion of the ultrasound scan? First of all, the presence of peristalsis in the intestinal loops, the presence of blood flow in the solid content of the hernial sac on the color flow mode. Of course, if your device has a color Doppler option, the presence of grayscale signs of necrosis of intestinal loops, thickening, changes of structure, the presence of echo signs of gametopia inguinal ring diameter optional, the ratio of the diameter of the neck of the hernial sac to the bottom, not necessarily an indirect criterion for strangulated hernia. The surgeon will understand this in case of unsuccessful attempt to correct it. Of course, he or she most likely will not do this if, in conclusion of ultrasound scan, you describe the echo picture of the necrosis of content of the genial sac. As in many other cases, ultrasound is only an initial method for visual diagnostic of the groin area, and to clarify diagnosis, computed tomography or magnetic resonance imaging can be recommended. But in practice, this happens very rare. Some case from my practice. The case of inguinal hernia, a middle school child in the Children's City Hospital was sent for ultrasound scan with diagnosis of edematosis scrotum. On ultrasound, we see a solid content without peristalsis, presumably the omentum in the inguinal canal. Another case of inguinal hernia with hydrocele on both sides, an infant with hydrocele and suspected inguinal hernia in the Children's City Hospital, sent for ultrasound. On ultrasound, we can see anechoic content in the both hemiscrotum as well as intestinal loops inside of inguinal rings or upper third of the inguinal canal. We can see it here. Next case, inguinal testicular torsion and inguinal hernia, 2-year-old child in the Children's City Hospital with complaints of mass in the left groin that appeared 2 days ago, and after examination of surgeon, he was hospitalized and sent for ultrasound. Ultrasound, we can see a testicle in the inguinal canal with a heterogeneous structure without blood flow at CFM color flow mode. We can see it here, the testicle. Another case of inguinal hernia with an ovary. A newborn girl with a mass in her groin in the Children's City Hospital, sent for ultrasound with suspicion of inguinal hernia. On ultrasound, we can see follicular structure in the inguinal canal. We can see it here. With blood flow at CFM only in the vascular pedicle, hernia neck, which is here. Another case of strangulated inguinal hernia, an infant in polyclinic was sent for urgently by a surgeon for ultrasound scan. On ultrasound, we can see intestinal loops in the inguinal canal with a narrow neck. You can see it here, thin neck. Another case of inguinal hernia with an ovary. We can see the ovary in the inguinal canal. Looks like kidney. Thin neck. Another case of inguinal hernia with an ovary with single cystic appearance. Which can be misinterpreted as another cystic mass lesion in this area. Another example of inguinal hernia with a vermiform appendix. A 9-year-old child came to a clinic with complaints of groin area enlargement and sent for ultrasound scan after surgeon consultation with suspicion of inguinal scrotal hernia. On ultrasound scan in the prone position in the groin, there is only fluid, but in the standing position we can see a crescent sign, solid content, presumably omentum, and even an appendix. Recurrent inguinal hernia in our case, a 5-year-old child in the Children's City Hospital with complaints of enlarged groin in the postoperative area. This is a condition after inguinal hernia surgery. On ultrasound, we can see solid content in the inguinal canal, diameter, intestinal loops. Another example of strangulated inguinal hernia with hematopia necrosis of intestine. We can see on ultrasound narrow neck of the hernial sac here, intestinal loops, some lesion with septa, which is hematopia. And after the correction of the hernia, we can see some structure, lenticular structure in the inguinal canal. And after reposition of the hernia, blood was obtained per rectum and surgery was performed in this case. Another case, this is inguinal hernia with intestinal gas, reverberation effect. A newborn with suspicion of strangulated hernia sent for ultrasound scan, and we can see the echo pattern of reverberation, like a lung echo pattern, lung with an air. We can see it here, testicle and intestine in the inguinal canal with gas. Inguinal hernia with a vermiform appendix, it is another case. We can see appendix in the scrotum and another intestinal loops. This is newborn child with enlarged scrotum. Sent for ultrasound scan, and we can see the solid content, anechoic content with septum, intestinum with thickened wall. This is pia cell and inguinal scrotal hernia. Another case of inguinal hernia with reverberation artifact from gas in the intestine. We can see it. We can see it here. This intestine in the scrotal, in the inguinal canal. A case of three inguinal hernia in the same child. We can see it 1, 2, 3. Which was confirmed in the surgery, and one side it was two of them, direct and indirect. Another case, it is of mass lesion in the groin, and this is an enlarged lymph node, teenager with complaints of pain. We can see a lymph node with increased blood flow. This is acute lymphadenitis. Another example of enlarged lymph nodes with destructive lymphadenitis. So we can see enlarged lymph nodes with unclear contour, with some gypaechoic lesion around and gypaechoic fat tissue around. This is destructive lymphadenitis. Gypaechoic lesion is an abscess. And another case, this is a rare case of lymphomatosis of spermatic cord with idiopathic necrosis of fat, with reverberation artifact like gas, and this is an infant without any complaints on screening. In ultrasound we can see in the scrotum some gypaechoic mass lesion on both sides of scrotum in both gemiscrotum. Thank you, that's all.